Okay, what an amazing start to the day. Who would agree with that? Don't we all want to hear all great things and both sides of the story? I was super excited to be a part of that panel. We are transitioning now to our next panel, which is going to be on the economic and political healthcare forecast for 2025. So we start at a macro level. We'll hang in the first half of the day at the macro level itself, and after lunch we'll start switching gears and going a little bit more micro. But super excited to introduce the moderator for the next panel, Ms. Kristen Hwang. Kristen is a health policy reporter for CalMatters, covering healthcare access, reproductive health, workforce issues, drug costs, and emerging public health matters. Her work has been recognized by the Association of Healthcare Journalists, Radio and TV Digital News Association, California Newspapers Publishers Association, Asian American Journalism Association, and the Sacramento Press Club. Please join me in welcoming Kristen, who's going to introduce the next panel and get us going.
Thank you very much. Good morning, everybody, and welcome. I guess I don't really need to introduce myself, but I will quickly. I am a healthcare journalist with CalMatters. We're a nonprofit news organization based in Sacramento that covers California state politics and policy. So I will be moderating the panel with these two wonderful people I'm joined with on stage. Dean Rosen, a partner with Mehlman Consulting and a longtime expert on the Hill on all things United States health policy, and also Katie Heidorn, who is the health policy director with the California Healthcare Foundation and who has more than 2 decades of experience in health policy and government in California. Both of these formidable minds are going to help us make sense of some of the federal policy changes that are coming out of Washington, D.C., and then we're also going to take a deep dive into California. I'm going to start with Dean. To set the stage a little bit, the November election was hardly about healthcare at all. Abortion surfaced a little bit in the debate, but that was primarily a very narrow ideological issue. We didn't have, like previous elections, these big sweeping discussions about changing the Affordable Care Act. We didn't have COVID looming quite so large over all of our heads. What we had were voters who were very concerned about the economy, about inflation, and about immigration. But if you fast forward several months from November, what we're seeing now is that healthcare spending and policy are at the center of all of the debates that are coming out of Washington, D.C. So I will let you take it away, Dean, to give us some more insight as to why that is and where we might be headed.
Thank you so much, Kristen, and thank you all for having me. I really appreciate everybody here at UC Irvine for having me back again, and it's a really interesting year. I think Ovik and Sherry did a great job, actually, even though we didn't do a lot of planning and coordination. Hopefully this will work. Let's see. Let's see if I can get this working. The right side, I assume, is clicking ahead, but that's not the case. There we go. Okay. You know, I think that they did a nice job of sort of teeing up the philosophical predicate for both a more conservative and more progressive approach to healthcare. Unfortunately, in Washington, we don't have as much clarity of direction, and I think what I'm going to try to do, and I know Katie's going to do the same in California, is try to provide at least a little bit of context. And Ovik talked about the fact that he wasn't going to get into the nuts and bolts of some of the details around what was being talked about in budget reconciliation or the executive orders, and I'm going to actually get into a little bit of those details, so hopefully it'll be complimentary. Now, quickly, all right, who's fixing this? Those of you who've been here before, quick show of hands. Okay, so you know that normally I try to, because we're close to the Academy Awards, try to put into context the health policy debates in Washington in the context of what's happening in the best movies of the year. I have to say this year, I'm not gonna do that. I don't wanna disappoint people. First of all, I'll just say as a personal preference, I grew up in Minnesota. I am a huge Bob Dylan fan. It was so hard for me not to talk about Timothée Chalamet and A Complete Unknown. But the fact is, and I think you saw this a little bit with Sherry and Ovik, these are very, very heated and passionate times. And when I looked at some of the names, usually I can try to find one or two films that really encapsulate where we are in Washington, but it's so charged right now, and there were so many names, I thought it was best to just stay away from it. Think about it, The Brutalist, Wicked, I Think She Was Misunderstood, Inside Out 2, Death by Numbers, and we're going to talk about that with Medicaid here in a moment. And then ask your kids about this, but Wallace and Gromit, Vengeance Most Foul. So there were just too many films, and it was too much of a heated time. But anyway, I'm going to talk for a minute about the big picture of Trump 2.0 and what we're seeing with the presidency before we dive into a little bit of healthcare and then what's going on, just to try to provide a little bit of a broader context, at least from my perspective. So here we go. So it's different and the same, I would say. This is only the second president in history and the first since the 1800s that there have been two non-consecutive terms. So we are living in many, many ways in historic times. So what's different this time around? I think the attitude is different. The president understands the role of power more than he did the first time. He's more aggressive, he's more in a hurry. And I think we've seen that the Trump 1.0 in 2017, the sort of disrupt and dismantle has now been replaced with a theory of let's replace and remake. Domestic politics, maybe they'll get it figured out. Maybe your governor here will rise to the occasion. But right now, a direct quote from the New York Times in a story a couple weeks ago from a very well-known House Democrat said that the Democrats are lost and in disarray in their own words. So there's no organized opposition yet. Trump has also taken over the Republican Party. Remember back in 2017, you had Paul Ryan and Mitch McConnell leading the House and the Senate, two establishment Republicans, and there was a lot of resistance in the cabinet we'll talk about in a moment too. There was a lot of talk about putting guardrails around Trump. Now, this really is his party. And on the world stage, we're in a time of war, both in the Middle East and in Ukraine, as we've seen. The U.S. is in a stronger position, and Trump's more senior. What hasn't changed is the sort of chaos theory that we saw the first time around. The fact that the president is really not a traditional ideological Republican. He's clearly got some guideposts, but is much more transactional. And the goal is just to dominate and sort of flood the zone in terms of the news, in other words. We've seen this early on, and this is just by the numbers, but this is a very aggressive use of executive orders. And this is going back to the Reagan era, the first month, so in January, you can compare. Trump had 45 executive orders in January compared to the next one was Biden in 25, but look at his predecessors. And then so far, and actually now it's about 90 since I finished my slides 2 days ago, but we've got an aggressive use of executive orders. The team is different as well. And the way I look at it is, on the one hand, and again, I'm just trying to provide a little context before we get into healthcare. On the one hand, he's repeating what worked last time around. I mean, you look at some of the folks in the economic and the foreign policy team. You had Steve Mnuchin, trusted by Wall Street. Now you've got Scott Bessent. You had, in the foreign policy space, Nikki Haley and Mike Pompeo. Now you've got Marco Rubio and Elise Stefanik. They're known quantities. On the other hand, there's a lot of change in some other areas, including healthcare. I mean, you could not get much different than Tom Price and Fauci, two establishment folks who've been around, and RFK and Dr. Oz. The same with law enforcement. You had Jeff Sessions, and now you've got Pam Bondi. And probably nothing summarizes the disrupt what didn't more than what we're seeing with Elon Musk and the Doge effort. So a little bit of context. I think there's some similarities, but also some differences. Again, when I think about trying to provide context and just framing for what we're seeing as an intro to healthcare, I think there are four big initiatives. One is trade. Clearly, the president is not scared. He says it's one of those beautiful words in the dictionary is tariffs. very romantic with Melania. Extreme budget cutting, we're seeing that. Taxes and reconciliation, which Sherry talked about some of the trade-offs, and we will in a moment. And I think a much more robust and muscular policy toward border and immigration, even than we saw in Trump 1.0. We moved from some of the concerns about child separation to mass, at least significant, deportation. There's some other things on the menu as well. And again, it's a very aggressive, I think in my 30 plus years in Washington, probably one of the most aggressive presidencies out of the debate. So undoing the Biden executive orders, AI, healthcare, redoing initiatives, ending quote unquote woke Democratic initiatives, going after the private sector. In one of the early executive orders on DEI, the president authorized the Justice Department to go after in lawsuits a number of large institutions, corporations and foundations and others, overhauling the deep state, as Republicans call it, replacing workers with tech. We're seeing that in the Musk realms. Cutting regulations. The president issued an EO, an executive order, a couple of days ago that said for every new regulation, you have to cut 10. Less antitrust scrutiny, except in the tech world. Ending a lot of the green subsidies that we saw come out of the Biden administration and the Inflation Reduction Act. And much more supportive. I know you're going to have some panels later today on AI, but much more supportive and much more laissez-faire policy toward crypto, open source AI, and accelerating technology in the defense world. So far, these are the numbers looking at the average of a website called Real Clear Politics. Trump is more popular today than he has ever been. His net favorability is in the positive range, and I think this is emboldening him. I mean, he's somebody who looks at these statistics, and you see it right now. Now, look. As a favorite quote I have from Mike Tyson, for those of you who are boxing fans, that every fighter has a plan when they go into the ring until they get punched in the nose. And there are some things that might affect Trump's plans. One is, how are the financial markets going to react? We saw the economy, as Kristen's question pointed out, was a huge factor in the first election. Public opinion could change, judicial review, violent events, both domestically and overall. The other thing is, resistance, as we saw in the first Trump administration and the Biden administration, is going to come from states like California and others. And these multi-state lawsuits, which we've seen more and more use, the courts right now will appear to be, with an all-Republican Congress, probably one of the most important backstops to what the president will do. But we'll have a lot of litigation, and I would bet that number of lawsuits goes way up over the next 4 years. Talk for a second at a broad sense about the Trump agenda, and then I'm going to get into the healthcare agenda in Congress, which is, I think, where the rubber, in a lot of ways, is really going to hit the road, and a lot of the issues that rubber's going to hit the road, and a lot of the issues that Sherry raised are going to be really, really important here. First of all, I mean, I don't have to tell anyone, but RFK is a very different HHS secretary than we've ever had. Certainly, as a former Democrat, one of the examples of how Trump is really looking to outsiders and disruption. And he's one that I think Washington, at least, is having a hard time getting their kind of arms around, because a lot of folks believe that we should, both sides of the aisle, we should look at the root causes. Ovik talked about it earlier, and maybe rely a little bit less on just a quick and easy pharmaceutical fix in some cases, but look more at the underlying diseases that are leading to chronic illness and nutrition and other things. But there is this long history of vaccine skepticism at the least, and will be a look at the agencies, particularly FDA, CDC, and NIH, in terms of corruption, and that's a big part of his agenda. I think he will leave a lot of the Medicare and Medicaid agenda to Dr. Oz, who I think will get confirmed RFK was confirmed last week. I think Oz will probably get confirmed in March at some point. But when you look at the Medicare, Medicaid, and Affordable Care Act agenda, it's a lot of going back to Trump 1.0. On the MA side, I think a lot of greater reliance on Medicare Advantage. They'll look at efficiencies, and we'll talk about this in a moment, I think across Medicare and Medicaid, despite what the president said, and keep your hands sort of off of Medicare, maybe off of Medicaid, maybe not. I think that we're bound to see some reductions in Medicare spending and some changes that they will characterize as greater efficiencies, pro-beneficiaries, and that will be in the eye of the beholder. On Medicaid, I think, and we'll hear from this with Katie in a moment, who knows a lot more about what's going on here in the state, but I think you'll see a lot of state flexibility, a push toward work requirements. I think that'll be part of the 1115 waiver processes, and you'll also be a push in Congress for work requirements, as well as budget caps. And I think it's sort of open to debate both in Medicare and Medicaid. We've seen a huge growth under both Republican and in particular under Democratic presidents and Biden in the use of supplemental benefits, both on the Medicaid side and the Medicare side in the last few years. And I think a question that to me, an open question, I wish I knew where it was going, is, do those kinds of benefits, be they housing, be they home delivered meals, does RFK and the new administration look at those as helping to fight chronic disease? And I think Ovik mentioned in his talk the importance of GDP, but we know that a lot of people's health outcomes are not tied to the healthcare system. Do they look at those as improving health, or do they look at those supplemental benefits more as waste, fraud, and abuse, TBD? We can talk about the drug policies here in a minute. I think there will be a continued fight in fentanyl and opioids, and we'll see what they do with the Inflation Reduction Act direct negotiations of government. I'm going to skip over this, but you have the slides. There's some particular executive orders that impact more directly healthcare on COVID and other things. So again, refer to the writing. Let me move to the healthcare agenda from the Trump sort of view of the world and the broad framing of how I think he's approaching things to what Congress is going to do, because this is really, I think, where we're going to see action and a lot of what was teed up in the previous panel. So the executive orders are easy. Getting stuff through a Republican Congress is going to be really, really, really hard. There's a 3-vote majority in the Senate for Republicans, and this is, as you can see, the smallest House majority of either party since the 1930s. So literally on all these things we're talking about, taxes and Medicaid reductions and work requirements and energy and everything else, you can only afford to lose 1 or 2 senators, but you almost can't afford to lose any House Republicans. And there are some folks in the Republican caucus who are very, very single-minded, and we've seen that, and this is going to be a huge challenge when you look at the majority. It literally is, when you look at Speaker Johnson's job here, going to be very, very challenging. And this is the timeline, and these are some of the challenges that they're going to face. First of all, right upon us within the next month, we are going to have the government funding run out in mid-March. That's the first thing they're going to have to figure out by March 15th. By the way, when they passed what they call a continuing resolution to fund the government back in December through March, they attached to it a number of Medicare and Medicaid, what they call extenders, but these are special rural payments, for example, for hospitals. They're the telehealth flexibility for Medicare. They're protections for hospitals from cuts that have never gone into effect from the Affordable Care Act around disproportionate share coverage, and all of that will come to an end in March with some kind of bill potentially, or we could have a shutdown, which I'll talk about in a moment. Guess what? The Senate is voting as we speak right now on a budget resolution, and the House is supposed to vote on a budget resolution next week. Now, how does that tie into funding the government? That budget resolution, I see Murray, who did hard time at the Congressional Budget Office, so he can correct me on this, but that budget resolution doesn't have to be signed by the president, but both the House and the Senate have to pass an identical budget resolution that has big numbers, go cut this in taxes, go reduce this in terms of healthcare spending. And once they do, then the committees in Congress will fill in the details. This is what Sherry talked about, Medicaid changes, Medicare changes, tax cuts, and other things. That they have said is going to happen also in the next 2 weeks. So you have this very partisan activity of Republicans trying to pass a blueprint that's going to govern what will be a Republican-only bill to extend the 2017 Trump tax cuts and offset some of that by making changes to health care and student loans and other policy. At the same time, back to my chart about the House, you see the majority of 4 or 5. Guess what? There's 20 Republicans who've never voted for a continuing resolution in the House. So it's going to make it really difficult, and what they're going to need is Democrats. And Democrats are saying, you know what? I don't really think I want to be part of a spending bill with Republicans because I already spent money last year when I agreed to it, and guess what? Elon Musk is firing all these federal workers and telling me that I'm going to impound it. So I think we could be heading to a shutdown, at least a short one, on top of all this, and we can get into that. At the end of the day, the other big deadline here is once a resolution gets passed, it would be political malfeasance of the highest order for Republicans to allow $4 trillion plus in tax increases to go in effect. So the end of the year becomes a huge deadline. This is the slide shows some of those healthcare extenders that I talked about that are tied to this March bill that are expiring in some more detail. And that's the next thing we're going to debate. And then on the budget resolution, and I'm going to just have another slide or two, and then I'll conclude here in my last couple of minutes. This is sort of the difference. You've got the House and Senate moving forward. Remember I said they have to pass one bill to allow them to pass the details of it, and we'll talk about the details on Medicaid and taxes in just a second. But right now, the Republicans in the House and the Republicans in the Senate have a very different idea about even how to move forward. So the Senate bill that's on the floor right now has no tax cuts. It doesn't contain any authority for the Senate Finance Committee to do anything to extend the Trump tax cuts. Why? Because Lindsey Graham, that's Lindsey Graham, who's the chairman of the Senate Budget Committee, and a lot of Senate Republicans believe that the best thing to do is get President Trump an early win around some of the things that Republicans are united about. The tax cuts is going to be really messy. You've got states like New York and California that want a higher cap on state and local taxes. You've got other states that want different things. But boy, Republicans all agree on 2 or 3 things. Number one, at this tough time, we want to protect our military. Number 2, we want more energy production and less reliance on some of the quote-unquote woke Biden policies. And number 3, we want to protect our border. That's what the Senate bill does. It spends $300 billion. Most of that would be paid for by canceling the Biden student loan forgiveness. Some of it might be some Medicaid changes, perhaps work requirements, perhaps I think repealing some of the Biden regulations on nursing home staffing ratios. But that is what the Senate is voting on this week. The House Budget Committee last week, which is really dominated by conservatives in the so-called Freedom Caucus, passed what President Trump is calling one big beautiful bill. So we're either going to get one big beautiful bill or 2 medium-sized beautiful bills. The House bill has $4.5 trillion in tax cuts authorized, $1.5 trillion in deficit reduction, and this is where healthcare comes in. And by the way, if they don't offset some of the taxes, there was an amendment offered that would allow deficit reduction to go up to $2 trillion. You heard the reasons why in the first panel. About almost $900 billion of the $1.5 trillion is directed to, they tell the House Energy and Commerce Committee to go find those savings. Now, why is that important? The Energy and Commerce Committee has jurisdiction over Medicare, but also over Medicaid. So that's why Sherry and others are saying you're going to have to target Medicaid. And it also does for the first time, increases the debt ceiling. Conservatives have agreed to that. They never wanted to increase the debt ceiling, but this increases the debt ceiling so they don't have to deal with it during Trump's 4 years. So that's what the House bill does. So if these both pass, they'll have to reconcile it and figure it out, and I do not know where it's going. This is the Committee for a Responsible Budget estimating the cost of extending for 10 years, the Trump tax cuts, plus the other things he promised on the campaign trail. And this is a little bit more of a detailed table. Again, you can look at this of what Sherry sort of laid out. And I think what I would simplify this is the 10-year savings estimates on the right column of these proposals in the biggest possible form. This is a brief description. What I think is most likely Republicans are probably going to unify around are work requirements and repealing some of the Biden regulations that save about $100 billion. Some of that is more flexible Medicaid enrollment, some of that is long-term care staffing requirements. Where it gets really, really tough and where some of the big savings are is, do they do per capita caps? Or do they do per capita caps only on the ACA expansion population? And I think the debate that Republicans are having is they know it's politically difficult. And I think the question is, we'll know this in the next couple of weeks, do they adopt a policy that says, you know what, we're not really cutting Medicaid, we're gonna reduce enrollment and reduce payments for the ACA. So Ovik talked about this, Sherry talked about this. I think those of you who study Medicaid, Katie knows this. The expansion population federal subsidy was 90%, really an incentive to expand Medicaid for states who had not done it for those who are eligible. So there's a lot of talk about, and this is one theory, maybe we cap that. Maybe we put a cap only on that. Maybe we reduce that amount and we blend the rates in a place like California, which would have a huge impact, which Katie will explain in a minute. The other theory is, you know what, let's just go after blue states. Let's try to protect Republicans. So what kind of policies would you adopt if you were trying to protect blue states? Well, the biggest one is, and it's up here as one of the options, would be to reduce the federal Medicaid match rate. There is a minimum match rate of 50%, and one of the proposals that is being talked about is, well, maybe we take that 50% in places like California and other places that have a minimum match, and we reduce that to something below 50%, 45% or others. Now, one or two of those states are red states, but most of those states are blue, and I think that's where you're gonna see the debate happen. But again, I don't know if they're gonna have to save 1.5 trillion or nothing. We'll know all that in the next, but I would bet that a lot of this will be under discussion for the next couple of months. I'm going to leave aside some of the other major health things that are being talked about, some of them in a more bipartisan way. This is really dominating the discussion right now, is the tax cuts and how to pay for them, as well as the individual actions that I talked about with President Trump. So I'll end there, and I'll look forward to Katie's comments, and I'll look forward to your questions, and I really appreciate your time and really appreciate the opportunity to be back with you. Thanks.
So I promise there's going to be plenty of time for audience questions at the end. Thank you so much for that presentation, Dean. I did want to ask you one follow-up regarding that nearly $900 billion in cuts that will sort of inevitably in some way touch the Medicaid, Medicare bucket. I think healthcare is a really interesting industry in America because it's not a monolith, and different sectors of the industry are going to be impacted in different ways by these potential cuts. You represent, a lot of clients that are on that diverse spectrum. I'm curious where you see, who might be the biggest winners or losers, and sort of how much sway do those industry sectors have in Washington, D.C.?
That's a great question. Well, please do not tell any of my clients what I just said. My clients are really very, very diverse, and I think it's a great question. I would say right now, the biggest potential quote unquote losers, or I would just say the folks who have the most, they're huge winners in my mind, but the folks who have the most to lose, I think, are the hospitals and the health systems. When you think about it, if you look at some of those Medicaid changes, you're already dealing with really low reimbursement, and Katie may want to comment on this too. I think most of the hospital and health systems are very, very concerned. Again, some of these proposals on per capita caps versus lowering the FMAP might affect different states differently, but across the board, hospitals are at huge risk. And then you look at some of the Medicare reforms, which despite what President Trump has said, I think they're inevitably going to look at, which are things like site-neutral payments, which would, reduce theoretically to an average or a lower rate the payment for a service and rationalize that across different sites of care. That's a huge risk for hospitals. Medicaid health plans as well, Centene, Molina, and others, because of the Medicaid cuts. Right now, they're not talking about Medicare Advantage changes, but I think coding adjustments and other things could be on the table because, again, this is really going to be a risk. I think, by the way, pharma and biotech, depending on what RFK may do, might have more of an administrative effect. But my sense is that hospitals and health systems, maybe followed by health plans that serve Medicaid, are at probably the greatest risk. And the last thing I didn't talk about, but there's another big issue and another big policy that's going to sunset at the end of this year, which is the Democrats, as part of the Inflation Reduction Act, provided enhanced ACA subsidies, really coming out of COVID, but extended them. Millions of folks will otherwise be uninsured if those sunset. And hospitals and health plans have a lot at stake in terms of their bottom line. It's not just patient advocates and others. And so if you just think about the healthcare sectors, that is another big risk on top of potential Medicaid cuts or site neutral.
Yeah,
Thank you.
If I could just add. Sure. Can you guys hear me? If I could just add, I think, Dean, you're absolutely right. And also, when hospitals, for example, are impacted, what's the impact to the community? So I think that's taking that, when I think about California, if our hospitals if our state budget's impacted, if our hospitals are impacted, if our health plans are impacted, what does it look like in the community? And I think that that's a big part of that. Hospitals employ people and hospitals deliver babies. And so you start to have to make really difficult decisions within a particular community.
Yeah, well, let's dive deeper into that and turn now to California. California has made some incredible investments in healthcare over the past decade and a half. Today, only 6.5% of the population is uninsured, compared to more than 17% back before the Affordable Care Act passed. That's the single largest percentage point drop out of all of the states in the country following the implementation of the Affordable Care Act. Last year, the state expanded Medicaid coverage to include all income-eligible undocumented immigrants. And this year, a record-breaking 2 million people enrolled in the state exchange, almost all of whom, as Dean mentioned, receive some sort of financial assistance to afford their health insurance. And the state has also gone far beyond in benefits in terms of what's required, expanding benefits. If you have Medicaid, you want acupuncture, California has you covered. But as we've heard from Dean, there's a substantial amount of uncertainty coming from the federal government, paired also with California having faced a multi-year, multi-billion-dollar deficit over the past few years. So, Katie, we will turn to you to tell us more about California and what's at stake.
Okay, slides made it. Thank you, everyone. So hi, everyone. Good morning. I'm Katie Heidorn with the California Healthcare Foundation. Really a pleasure to be here with you today in person. I spoke at this conference a few years ago and got to do it via Zoom, so it's really lovely to actually be in this auditorium with you all today. So as Kristen said, I'm going to take us away from the federal government and really try and focus on the brass tacks. What happens in California? What's going on in our state right now? And what types of decisions are our policymakers going to have to make? So our state, I want to start with our state budget outlook, because this is really what dominates California's political space in Sacramento every year at this time of year. From January to July, we're focused on the budget. So as January 10th, our California state budget is actually balanced. As Kristen said, we've spent a few years with some really major budget deficits, and the governor and the State Department of Finance last year decided to solve that budget problem not only for the current budget year, but for the budget year after. So they were really trying to be good stewards of California's fiscal situation. And in my nearly 20 years, I have not seen us do that before. It was actually really thoughtful. And we're also, if you look at some of the analyses coming out from our state legislative analyst's office and the Department of Finance, we also might have tens of billions of dollars in structural deficits going forward. So while our current state budget is relatively balanced, and we have a very small surplus of $363 million as of January 10th, we're still in a pretty precarious financial situation. And our tax revenues were also up billions of dollars from what our estimates were. So in terms of healthcare, this is actually a pretty boring budget. Usually on January 10th, the entire city of Sacramento policy community is sitting there waiting with bated breath for the governor's press conference. And it was really boring for healthcare, boring in a really good way. The governor maintained coverage for all undocumented immigrants. There are no major health and human services cuts for the first time in a long time. And then he also maintained funding for our Medi-Cal transformation program, which many of you probably know as CalAIM. So we're really actually sitting in a pretty nice space in the health and human services world. Similar to the federal government, there are only a few places in California where you have what we call general fund monies, where our state tax revenues come in and we spend that money on healthcare, prisons, transportation, climate, education. There are only a few places where you can actually cut general fund money if you have to make budget cuts, and Health and Human Services is one of those places, and most of that comes from the Medicaid program, no surprise there. So the fact that we're actually sitting here with no cuts in the budget is actually pretty exciting. And we have some considerations. Obviously, all the questions about all of the proposals that my three colleagues outlined for you this morning, huge, just big question marks floating across everybody's head. There's no clarity, there's no certainty. As you said, we all wake up in the morning and check what happened yesterday. You know, even on a Sunday morning, we're checking and going, was an executive order put out this weekend? Did DOJ access more data or stop more payments? Did somebody file a lawsuit? Right? It's just really fast moving. I'm sure this is the same, you all are probably feeling this as well. And so while we feel like our budget is in an okay space, the reason there aren't many things that have happened in our state budget this year is because we just don't know. We just don't know what's going to happen. And then I just said, as of January 10th, the budget was balanced. What was happening during January 10th? LA was burning, right? So the governor unexpectedly had to sign a $2.5 billion relief package to LA. And as we know, that's just a fraction of the cost and the time that it's going to take to help rebuild the city and support everyone who lost their homes and resources. And then we also are going to have an incomplete revenue picture because of that disaster. You'll probably remember with some of the storms last year, we delayed many, many tax revenues and tax filings. And so the way our budget works is that we sit here and from January 10th, we have a budget that comes out, and you'll see up here on the slides, the legislature has to send a balanced budget to Governor Newsom on June 15th, 2025. We collect taxes on April 15th. We get a good revenue picture. We revise the budget in May, and that allows our state legislature to send a balanced budget to the governor. If we delay, all of those tax receipts have been delayed until October 15th. We don't know what our revenues are going to look like in May. So with the federal uncertainty and the major revenue, and you can imagine LA is a huge returner of tax revenues to the state, we really don't know what our inputs are going to be, and we don't know what the impact of the federal government is going to be. So we're all sitting here with lots of questions. So what's happening next in the California state legislature? As I said, our budget was introduced by the governor on January 10th. We also have bills. So all of your senators and state assembly members are introducing bills. Their deadline is tomorrow. So tomorrow we're going to know what bills are going through the state legislature. As I mentioned, we've got the May revision of the budget coming in mid-May. Again, we won't know what our revenue picture is going to look like. The legislature has to send a balanced budget to the governor by June 15th. It's required by our Constitution. And then our new state fiscal year begins July 1st. And then bills have to be delivered to the governor for signature by September 12th. So that sort of gets us through the end of the federal fiscal year. And that gets us through our whole California state legislative cycle as well. In addition to all of this federal uncertainty, what are we expecting to see introduced in the California state legislature. We have the budget, which is running on one track, and then we have all of these bills that are being introduced by tomorrow. Artificial intelligence regulation, big topic today. I'm actually thrilled that that's part of this conference. I was delighted when I saw the agenda, so kudos to the planners. The Biden executive orders were rescinded a month ago. Our regulatory landscape for AI looked way different before that, and California is not to be outdone, not only by the federal government, by our other states. So we've got people who are really interested in regulating and digging into artificial intelligence. Climate change and community resilience, because of the LA wildfires, we're seeing a lot of community resilience and climate bills that are coming out. We still have a homelessness crisis that I'm sure everyone here is aware of. It's a huge priority of the governor and a huge priority of the members. That has not gone away. The governor's put a lot of money into it. And so I think over the next couple of years, we're gonna see how that money plays out in our communities. And then healthcare affordability. I would say that that's sort of the biggest topic. We talked a lot about it earlier today. Ovik, Sherry, Dean, we all talked about how important it is to make our healthcare budgets sustainable. California has something called the Office of Healthcare Affordability, located within one of our state departments, and they are really actively looking at all the data across both our public and our private insurance markets, and setting different targets to try and bring the cost of healthcare down in the state of California. So, turning to what we're watching federally, I mean, Dean and Sherry and Avik really talked all about this, but I want to talk about what could have a big impact specifically in California. So not just broadly across the country, but really what happens in California. So I talked about our state budget, and I started with the state budget for a reason. Federal funds make up 1/3 of California's state budget. Our state budget is $323 billion. 1/3 of that, so about $170 billion, are federal funds. And most of those federal funds are located in our Medicaid program. Remember what I said our surplus was? $363 million with an M, not with a B. So when you start talking about these billions of dollars that we're getting from the federal government, our little surplus, it's not even what we call budget dust. It's really, really insignificant and small. If you're talking about how can we absorb any types of cuts in Medicaid, you can't absorb that kind of a cut. The big possible cuts to Medicaid, which we call Medi-Cal in California, they could have a $10 to $20 billion impact on our budget. Huge. How do we do that, right? Any of the changes in the FMAP that Dean talked about, whether we decrease the floor from 50% to 45% or 40%, if we take a chunk, if you change the 90% expansion population down to 50% or even down to 80%, California is so big that equals billions of dollars for us. Per capita cap, there's a reason that it says we're gonna save $900 billion over a 10-year period. That's a huge cut into any state's budget. And however way you slice and dice it, while states could have flexibility, that's still gonna equal major budget considerations for the state of California. And so there's a state budget consideration. So essentially any change to Medicaid, probably other than work requirements, will blow a hole in California state budget. I don't want folks to hear me say that and panic, because I think as my colleagues talked about, there's a whole lot going on at the federal level in terms of politics. These are very difficult votes for conservative Democrats and moderate Republicans to take. There are huge lobbying efforts from consumer advocates to labor to industry happening where people are being targeted. The House members are at home this week in their districts. There's a lot going on. I think there's even a town hall happening with some of our California consumer advocates about 20 minutes away from here today. So there's a lot of messaging and talking going on in both of these spaces. And the reality is if something like this happens, California is gonna have some real difficult decisions to make. And just like congressional members and senators, our California State Assembly members and our California state senators don't want to take chunks billions of dollars out of health and human services. They don't want to cut education. They don't want to cut transportation. They don't want to cut climate initiatives. These are really hard conversations to have, and California has been there. We were there most recently in 2008, 2009. They cut the budget for 4 years straight and only recently added back in some of those benefits and things that were cut during the Great Recession. So those of us that were in Sacramento during that time were staring at this going, wow, we know what this looks like. We know what that spreadsheet looks like that our Department of Finance has. Yes, they literally have a spreadsheet that says, here's what each, just like the federal proposals, here's what each of these things could cost. And they have to make and weigh all of those decisions. The next place to go, and we talked a little, my colleagues talked about this earlier, healthcare coverage enrollment. So if we have to cut that billions of dollars out of programs, out of Medicaid, you can't just do that. Nickel and diming, acupuncture, adult dental. A few years ago, we tried to reduce, during the Great Recession, we tried to reduce, I think it was emergency department payments by 10%. It just, you start nickel and diming. The way you get to big dollar amounts, to those $10 to $20 billion, you have to cut enrollment. It just equals people. And that's gonna be really hard for our governor, not only for our assembly and senator, and state senators to make. We've got a supermajority of Democrats. The Democrats do not want to take those votes personally, but also from a political perspective. The governor has committed to keeping all Californians on Medicaid who are eligible. He doesn't want to have to take those cuts, but that's really how you get to enrollment cuts. There are a couple other things that could impact enrollment. So even if we do have work requirements, it's less of a budgetary impact. And, as I think Sherry and Ovik talked about, it equals fewer people on Medi-Cal. It just does. California is famous for doing whatever the state possibly can to keep people enrolled. And even with the redeterminations that happened post-COVID, we still kicked off hundreds of thousands of people from the Medicaid rolls. So this would definitely impact enrollment. And same thing with those enhanced tax credits that for Covered California, for our state-based exchange. If those go away, those 2 million people who signed up for Covered California this year, we'll see some of those folks rolling off as well. And then the last piece, Dean alluded to some of this, we also have healthcare benefits and delivery system impacts. I'd say this is mostly a regulatory concern. We have an 1115 waiver that allows us to do Medi-Cal transformation, allows us to pay for housing benefits out of Medicaid, Medicaid funds, because we're really trying to get to the whole person and extend beyond somebody's healthcare. That waiver is going to need to be renewed during the Trump administration. And so I think, as Dean said, things like work requirements, et cetera, could be a bargaining chip on that regulatory side and not necessarily on the congressional side. So we're watching for all of that. And then, of course, we have these regulations that could possibly be rescinded, and our State Department that runs our Medi-Cal program is working hard to implement those. So you have people who are working to implement things, and then we might claw them back, and that changes the work that they're doing. I also threw up here graduate medical education. We have a huge workforce crisis in California. As part of balancing our budget for the last year, we cut out hundreds of millions of dollars that were dedicated to improving our workforce situation. And those are really easy dollars to continue to cut at our state level because they don't equal people losing healthcare coverage, and it would just exacerbate our crisis. So we're really actually watching quite a bit of what's happening in the GME space as well at the federal level. So I want to get down to who would be impacted. And we talked a little bit about this with Kristen's question to Dean. But I wanted to take it a little bit further and talk about the community and our markets and the people. This is what California's healthcare market roughly looks like. We've got, out of about 39 million Californians, we've got 19 million in employer-sponsored coverage. We've got about 14.5 million in Medi-Cal. It's a third of our state's population. I think someone mentioned earlier that half of the children in California are on Medi-Cal. It equates to about 5 million children. Medicare is about 6 million people in California. Covered California, as we just heard, hot off the press, we have 2 million people now in Covered California. And then our uninsured is still roughly around 2.5 or so million people. So as Kristen said, California's uninsured rate is the lowest it's ever been. It's an incredible accomplishment, and it's something California prides itself on, and it would be very difficult to maintain those levels of healthcare coverage without support from the federal government. So this is really what it comes down to. Who makes and influences the policy change in California? Our governor, obviously, and our executive branch. He controls our state budget, our regulatory process, and we have a lot of stakeholder input processes under that as well. I don't have the Attorney General up here, but I think in California that is one to absolutely watch. I'm sure all of you have noticed Governor Newsom was on the campaign trail for Biden and was all about not having Trump become the next president. And now he's turned around and welcomed President Trump to LA to talk about fire relief. There are different types of considerations now for the governor than there are for our Attorney General. Our Attorney General, Rob Bonta, has already sued the federal government 5 times in the last month. So it's really interesting to me to watch how sort of our two of our independent state leaders are looking at the Trump administration and responding, and that's something that I will continue to watch. The California state legislature, as I said, the folks who are gonna have to make big budget decisions on bills, on our state budget, that's the California state legislature, our assembly members and our senators. We obviously have our judiciary, probably less of an issue in California than at the federal level, although we're definitely watching what's happening, particularly on the immigration front in California at our state level courts. This is something to watch. And then we have our local governments. So we've talked a lot about the impact of Medicaid funds on our state budget. A lot of those dollars get passed down to our 58 counties. Public health dollars, mental health dollars, human services dollars. A lot of money there, right? And I didn't talk about our research institutions there. I'd say like a group that wasn't on this list until a few days ago, and I'm sad to put them on there, but they're also part of the folks I think who would influence and also are gonna be impacted by what's going on at the federal level. And then we have our third-party stakeholders. As I mentioned, there are folks out there from consumer advocates and nonprofits. We have our industry trade associations. Some of you maybe work for folks who are members of the California Hospital Association or the California Medical Association, our 2 health plan associations. They're all paying attention and working with their national counterparts to think about how they're going to respond to whatever proposals come out. We have businesses, small businesses. We have really big businesses. We have big businesses who do self-insured, and we have small businesses who are insuring their employees through Cover California. And then, as I mentioned, the researchers as well. So there are a lot of moving pieces in California, and there are a lot of people who have lots of interests and a lot of stake in all that's happening at the federal government and in the state. All right, I'm done.
Thank you so much for that, Katie. I do have a question for you, and then I'm going to ask both of you a question and then open it up to the audience. You made, the very sort of striking point that a third of California's state budget comes from the federal government. $160 billion of our state budget goes just to Medicaid, and $100 billion of that comes from the federal government. It's clear that any kind of tweaking with, FMAP, per capita caps, those kinds of things, that's like a hole that California just cannot afford to fill. Are there areas of progress that you think California has made in the past decade or so that will kind of be left behind?
Yeah, I think, Kristen, that's a really good question. And this goes back to even in 2017, I think 2017 was 3 years post Affordable Care Act. California had stood up our own state-based exchange. We'd expanded Medi-Cal to the expansion population, and we were well on our way towards expanding Medi-Cal to all undocumented immigrants. And when President Trump came in 2017, I know people in the California healthcare space were dismayed because they said, we thought we'd solved our coverage problem and that we could actually move on to addressing social determinants of health and addressing quality and access. And it felt like we were put back in that coverage conversation. And even though, as some of our colleagues pointed out, this Trump presidency was not based on repealing the ACA. That's where the money is going to come from to pay for tax cuts. And so it becomes a healthcare coverage conversation again, because as you said, and as I just talked about, if you're trying to cut billions of dollars out of a California state budget, that typically equals loss in enrollment. It's just really hard to get there otherwise. And our governor has also said he doesn't want to raise taxes, right? So there are only a few ways you can get there. So yeah, I would say it would push us back to a coverage conversation rather than keeping us in this space of what we're trying to do with our Medi-Cal transformation waiver and CalAIM, where we really are trying to get to paying for medically tailored meals and paying for housing and integrating and updating our behavioral health system with our physical health system. It would absolutely take people physically out of that system, but also would make it so that we can't put money into those things we care about.
Do you think, you mentioned the supplemental benefits, and I think this ties in with something that Dean brought up as well, like California's 115B waiver, is that the right? 1115B.
And 1915B, yeah.
Waiver for
A couple of them.
the Medicaid transformation. What do you think is going to happen with that waiver? Like, you mentioned whole person care, and that's something about, we're trying to address the social determinants of a lot of healthcare issues in California. A lot of the things which honestly, like RFK has said, he wants to address chronic disease and things like that. Do you see any bright spots maybe about something like that getting renewed?
Yeah, so I appreciate that, because we are always looking for bright spots, right? In any time, but particularly right now in the health space. First, there are two waivers at play here that enable our Medi-Cal transformation initiative. We have an Section 1115 waiver, and we have a Section 1915B waiver, just in case anyone's curious. And just as an aside, the California Healthcare Foundation has a Defending Medi-Cal in 2025 webpage. Big shout out to Ann Sunderland, who's here from our team, who's put that all together. Woo. We have tons of resources on there, so if you're curious what these waivers are, please go to that webpage. We've got everything on there, from fact sheets about who in Medi-Cal are working adults or live in working families, all the way to papers explaining what 1115 waivers and 1915B waivers are. So with 1115 and 1915B waivers, they're hard to repeal. So there are requirements that if the Center for Medicare and Medicaid Services wanted to actually not even wait until it was time to renew these waivers, they could theoretically claw the authorities and the money back. Doesn't happen very often and is very difficult to do. And so we don't expect that to happen. Looking forward, our Department of Healthcare Services, which is our state Medicaid agency, the agency in California that runs our Medi-Cal program, they actually seem very positive. They're talking to their Medicaid counterparts in both blue and red states. I actually had the opportunity to speak to a group of UC Berkeley students a couple days ago, and we had the former Secretary of Health and Human Services from North Carolina on as a presenter as well, who runs sort of essentially a purplish state. And he said that they essentially have a social determinants 1115 waiver that was approved under the last Trump administration. So, he said it's doing the things that RFK has been talking about, going upstream, investing in preventive care. So I actually thought that was really interesting. I don't know what that means. I think I don't know what that means for California, right? California has a target on us because we are California. It just is. And so even if they might approve something like that for, I don't know, Oregon, would they approve that for California on principle? I don't know. And I appreciated what he said, because it's clear that the Trump administration has, or the past Trump administration, has approved waivers that are, at least have components that are similar to things that we want to do. So I think we absolutely have our work cut out for us in terms of a waiver renewal, and I do think there's some light at the end of the tunnel on that.
Okay, I have a politics question for both of you. So the last time that sort of major structural changes to Medicaid were proposed, they were sort of tucked away in that ACA repeal and replace bill, which did not make it across the finish line. Now they're sort of front and center in the healthcare debate in Washington. Do those optics matter of we're going after Medicaid as opposed to the ACA? And how much does it matter that, as you mentioned, Dean, we have a very different Congress in front of us? This is Trump's party.
Go first. I've
Yeah.
got thoughts too, but so curious
Hopefully
what you're going to say.
hopefully we'll be more tame than the previous panel.
Sorry,
keep it
probably not as
exciting.
many fireworks. So
No, that was a lot more
it was
fun.
fun. We're boring. Sorry.
Well, I think it's no, it's a great question. I think there's a couple of different levels where I think the Medicaid cuts play in. The first is just the basic, political charge, which I think the Democrats will levy here as the Republicans get deeper into this, which is you're cutting taxes for the rich and you're hurting the poor. I mean, that's difficult on a surface level. The challenge, I think, is taking that one or two steps below that, because the tax cuts, again, have to get extended. They just have to. Can't be a Republican, can't be President Trump, can't control the House and the Senate and say, oh, all those things we did back in 2017, well, all those increases are going to go into place. And when Republicans designed those tax increases or those tax cuts in the Targeted Jobs Tax Cut Act, they because of the budget rules, which we won't go into all the details, but because you have to come within a certain spending limit within 10 years, what the taxes that are going to sunset at the end of the year largely are those that apply to individuals. So it's even more difficult for Republicans to not do it. It's not just that Trump wants it. It's a huge political and economic impact if all of a sudden we'd have to, assume that. So that plays into it. When you get a layer below it, I think there's two things. Number one, you're going to have a substantive dynamic where if you do have changes, this is partly, Kristen, to your question, which is a great question, what we saw back in 2017. I think one of the main reasons that repeal and replace didn't happen was that it was because of Medicaid. The changes hit every state really differently, and you don't have to be an ideological conservative to say oh my gosh, I'm from Louisiana, I'm getting screwed, or I'm from Ohio, which is now a red state, and Ohio expanded Medicaid, and so we're really getting hit. So that exactly happened last time. The difference, I think, number one, is that the tax cuts have to happen, whereas repeal and replace was something they wanted to do, number one. Number two, this will be, aside from the state thing, this will really be the fundamental debate, and we'll get a hint of this next week if the House follows through with their plans to put this budget resolution on the floor. The question will be, in the Republican Party, do the more moderate elements like Valadao in California, Lawler in New York, and others say, I cannot do this. I cannot vote for $880 billion. I know where they're going to get this, and it's going to hurt. Katie's going to tell me, show up the next day in my office and tell me what's going to happen in California. Or so are they going to hold their ground, or are the conservative members of the Freedom Caucus going to hold their ground? What I've seen traditionally is usually the moderates cave, and so we'll see. But that really is the fundamental argument, which is, on the one hand, and I think, Kristen, you really teed this up nicely, this campaign was not about restructuring Medicaid. This campaign for President Trump was about immigration, it was about the economy, it was about inflation, and to an extent, it was about social issues and foreign entanglements. And at some point, the Republican leadership understands this, and they're sort of saying to the Freedom Caucus guys, let's just cut taxes and get out of Dodge. We can make some other savings, but let's not totally restructure the Medicaid program. We can do $500, $600, $700 billion in changes, but once you get to $1 trillion, then you really start to get to tough stuff. On the other hand, the argument will be, will those guys just hold their ground, and will folks like Valadao and others have to accept something? But one way or another, they're going to get these tax cuts done, and I think Medicaid is really at the fulcrum of whether it's going to happen or not as to how much it's on the table.
Maybe to make that question a little more California for you, Katie, how susceptible do you think the California House Republicans are to calls to prevent Medicaid cuts?
Yeah, I mean, I think, as I noted, there are huge efforts, and I'm sure you've all seen in the news from both advocacy organizations and labor, talking specifically to David Valadeo in the Central Valley, talking to Young Kim right here in Orange County, and talking to Ken Calvert out in the Inland Empire. They are very clear and they know exactly who they need to target. There's also discussions of some of the more moderate or some of the more conservative Democrats, Mike Garcia in North LA, and a couple others. So the folks know who those people are. And, I think, they're looking to the midterms. The midterm campaigns kick off at the end of 2025. That's not very far away. So I think there's a very small window in which the sort of more moderate Republicans and the more conservative Democrats have to make these very difficult decisions because they're concerned about either getting primaried from the left or the right. They want to keep their jobs. And so I think they've got a real difficult thing in front of them. And they're worried about their communities. As I said, if they've got a hospital that's in jeopardy, if a labor and delivery ward is going to close, if in Valadeo's case, he's got at least 60% of his district is on Medi-Cal.
It's 67.
67, thank you. Almost 70% if we're rounding. And if anyone's curious what your district looks like, you can find that information also in some fact sheets on our website. So folks know exactly what they need to do, and there are going to be some real impacts in their districts. And, and all of those folks I just mentioned ran really, really difficult, really tight races, and they know that that's going to happen again in 2026.
Two really quick points just to follow up on that. I think, number one, part of the challenge is the process, which I sort of talked about, but you're going to have these budget blueprints, which are just numbers, even if they pass. And then the details are going to take months and months and months to figure out. So you could see, Young Kim or Valadeo or Calvert or others voting for this just to move the process forward. And then you really get into the weeds on what it means for Medicaid. The other thing is, in terms of the substance, and this may not be a positive message in California, but I think there is a lot of Republican consensus, and remember, this is going to be a Republican-only bill, around 2 or 3 things that they can do that are going to save hundreds of billions of dollars. One, work requirements required across the board at the federal level. As my chart showed, that saves about $100 billion plus. Number 2, there's a strong belief that Biden over-liberalized enrollment in Medicaid at the federal level, and there are things that he may have done that exceed where Republicans are willing to go policy-wise and may exceed legal authority, like requiring nursing home staffing ratios for all nursing homes at the federal level through Medicaid and in some cases through Medicare. So if you just repeal those Biden rules and you do work requirements, and by the way, you say, we're not going to provide, we're going to reduce the FMAP for states that have coverage for illegal immigrants or immigrants who've been here for a short period of time. I mean, I can get you to 400 or 500 billion, but I can't get you to trillion or 800 or 900 billion. And that's where the additional discussion comes into effect. And that, I think, becomes a challenge. Do you go get it more on the Medicare side? Do you maybe do some things that I talked about in terms of FMAP changes, maybe put them in the out years? Or do the conservatives say, you know what, we don't need to really do this once we see the details. We can assume some things like DOGE is cutting money, or the tariffs are going to bring in more money, or maybe we'll look elsewhere. So that's really where the debate's going to be.
I have a clarification question for you, Dean, and then audience questions. When you say the blueprint is just big numbers and say, that passes largely the way it looks right now, does that mean that when the committees are hashing out the details, like they are beholden to that number, they must meet that number? Yeah,
so the way this budget reconciliation works, again, Murray, you can come down and tell me, is basically the House and the Senate pass an identical blueprint that tells each committee in the House and the Senate what to go do. And so it'll tell the tax writing committees, you can, add 4.5 trillion to the deficit. It won't tell you exactly where to cut or what to extend. They'll assume that and they work with the committees in coming up with it, that it's this particular tax cut. So it'll be sort of clear, but it won't be clear till they actually do it. But yes, and they'll reconcile, or they'll tell the Energy and Commerce Committee, go find 880 billion. The savings numbers are a floor, so they can exceed those. So in the Senate resolution that I talked about, which is very different, they tell the Senate Finance Committee, this is the Senate side, they have jurisdiction over Medicaid and healthcare, go save $1 billion. Well, they're gonna save more than $1 billion, but that gives the committee a lot more flexibility to go somewhere between 1 billion and something higher. But yes, once they get to those numbers, they've got to meet or exceed them in terms of the deficit reduction numbers.
Okay, thank you. We can move on to audience questions now.
Relatively clear, clear as mud.
Thank you very. Is it on? Okay. Thank you very much for all this interesting discussion. And I'm really glad there's people that take care of old folks like me. But I'm a pediatrician. And as you know, nationally and particularly in California, a huge percentage of children are covered by Medicaid. And Medicaid already pays the lowest rates, and pediatricians actually earn the lowest salaries. And now we're seeing fewer and fewer people go into pediatrics because they can't afford to pay back their student loans on a pediatrician's salary. So we are moving into sort of a crisis in ability to provide care for kids if this continues for long. So among all these various discussions among the politicians and cutting Medicaid, is there any discussion of, of preserving something for the children because they can't have a work requirement? There is not a fallback for them to go to. So how do we make sure we still take care of kids?
I mean, I think that's, I appreciate your question and your point. I alluded to a little bit that we're watching graduate medical education funding at the federal level. There's some proposals to focus some on rural areas. We have a workforce crisis, not just in pediatrics, but across the board and in many different places. And so I think I think it's a broader conversation. I'm not hearing any specific proposals to ensure that we have care for children in that specific way.
And I think, you mentioned work requirements. That's a good example. I think if they do that, they'll obviously apply it to, able-bodied, and they may apply it to childless kids or other things. But the fact is that once you reduce enrollment, and Sherry made this point earlier, once you put any kind of restrictions in place, it's going to force decisions at the state level. And that's where, Katie, it's going to be up to you if there are changes. And there are going to be these trade-offs, right? Do you cut the care for kids who are relatively inexpensive, or do you cut the care for the long-term care population, which is much more expensive but may have more political clout in some cases? And a lot of these decisions, if a federal bill passes, I think the details are going to play out at the state level. And you're exactly right. The impact on pediatrics and workforce is going to be significant. And the Congress didn't do very much coming out of COVID, even though they know there's a bigger workforce challenge, as Katie said, to do much to address it. Because again, it comes down to dollars.
All right, we'll take your question.
Mm-hmm.
Thank you. Thank you for this great presentation. I've got a question for Dean. So in this morning's presentation, one of the things that I noted is the countries that are all clustered with similar healthcare costs and outcomes all negotiate with drug companies as countries, not as individual health plans. And that's one of the reasons why drug costs are so much lower outside the US. Why is it that the Trump administration seems they want to reduce healthcare costs, they want to reduce healthcare spending, but they seem completely opposed to the idea of negotiating for drug costs to reduce runaway drug costs? So I can't make sense of that. Can you explain it?
Yeah. I'm not sure I can explain it, but
Gosh, I'm glad Dean has this question.
It's interesting. In the first Trump administration, the president rhetorically was for drug negotiation. What's difficult to figure out, and I think we will, get some sense, because again, it goes back to Kristen's question. It wasn't really a detailed health policy debate in this election. Was they're sort of for negotiation, for some things like importation and other things which could control prices, which in some ways is a price control by adopting prices from other countries. But they don't like the details of the Inflation Reduction Act, which Democrats passed. I think that's in part because almost anything that Joe Biden did, they don't like. So it is hard on that level, to me, to almost reconcile not so much the drug spend, but the previous comments with the current sort of approach. I think the view is that the way the IRA was implemented was flawed. And I think beyond that, it just gets to almost a fundamental debate about where we are as a country and how you control it, that it almost would have been a really good question for the first panel, as you said, because you do have the view, and I don't want to put words in either Sherry or Ovik's mouth, but where Sherry was talking about, which is, look, we don't control prices, whether it's pharmaceuticals or other things like other countries. And what Ovik articulated, which is we have this capitalist system in the United States where it's sort of negotiation. The challenge is right now, I mean, as someone who's been sort of trying to navigate this for the better part of 30 plus years, is we have a pluralistic decision-making in the United States where 12 of the last 14 elections have brought change one way or another. And we really are either doing the best of both worlds or the worst of both worlds. We don't have a consensus right now of whether we're going to be more of a government-controlled system. I mean, the Bernie Sanders view is still very prevalent, or one that's based on something more like Ovik articulated. And I think because of that, we have this tension. Well, we'll tweak Medicaid a little bit. We'll put in place a work requirement. We'll, keep Medicare and Medicare Advantage, which was fundamentally designed, and I helped to draft the bill around drug coverage where it was going to be privately delivered, and it delivered lower costs than the government probably would have done. But is that a view of the world, or should we have negotiation? Then what we have now, frankly, is a lot of government layered on with a little bit of market flexibility, or a lot of market flexibility layered on with a little bit of government, but no clear direction. And that's probably the best I can tell you, which is the Trump folks are probably grappling with exactly that right now, which is they want lower costs, but they also want innovation and market flexibility. I know it's unsatisfying, but.
I think we had a question over there.
Thank you very much for sharing all your insights. It's always a pleasure to learn from you guys. Now, Dean, you had talked about change elections. You even just brought that up now. From your experience and looking forward in 2 years' time, do you think Trump and his new cast of crews are setting the stage for, and I know my movie trivia is a little older, Anatomy of a Fall? Or do you think this team really has...
That was a fantastic movie, Anatomy of a Fall.
Or do you think this crew has the substance? Meaning, is this a tsunami or is this a tidal wave that's going to keep going?
Just to follow up, I mean, particularly with respect to some of the health care changes, or more broadly in terms of economic and state. I think a little bit it's why I divided it into two columns. I mean, I probably make a controversial statement. I don't think the president is not a smart person. I think he understands sending a signal about international stability and market stability is really important to him. I think on the healthcare stuff where he's made the comment, I'm going to let Bobby kind of go wild, which I think is almost a direct quote, is almost a reflection of this healthcare stuff is not his priority, is not comfortable with it. It's not where he's really rolled up his sleeves. And so I think you're going to see, as you're seeing with Elon Musk and the Doge things, a lot of disruption that I don't think we ever anticipated, coming to fruition. Even a couple months ago when people were looking at what Doge was doing, I think a lot of people thought, even people who'd been around for a long time, that it was going to be more of an advisory. It is having, as Katie talked about, a real world impact on workers and on certain programs, and it will have a bigger one. So, I think the only way I can answer it, it's a little bit like the Anatomy of the Fall. It was a little bit unclear at the end who really did it. But I think that, I think it's going to be a little bit of both. I mean, he's clearly changing the norms in terms of how we're governing, and I think recentering or taking to a greater extent than ever, depending on your view, an executive branch power mode. And I think it's really going to be determined in some ways by, does Congress at some point stand up And in 2 years, do the Democrats win back the House, if not the Senate? And or do the courts stand up? And does Trump agree to abide by the court's decision? And I think that's going to probably say more over the next 2 years than I could.
Yeah, and I'd actually love to give a little California context here, Dean. I really appreciate your comments. But as we think forward 2 years and how much of this lasts, particularly in the healthcare space, because that's really where our source of federal funding is coming, we saw during COVID that the way that the governor handled the budget crisis, and then we had unprecedented revenues, actually, they actually kind of kicked the can down the road a year or two when they were budgeting, and they said, you know what? We're in the middle of a pandemic. We don't know what's happening. And so we're not going to make massive cuts or massive changes to the state Medicaid programs or other programs because we don't know what's happening and we want to see this play out a little bit. And so I actually think that we might see something like that, right? So even if massive cuts happen, there's sort of the implementation side of it. And if the Democrats win back the House or they win back the Senate, or, we get a completely different governance structure, or any of those things that Dean said happen, that also is going to have an impact, I think, what we're going to see at the state level as well. So, I don't know that if a massive cut happened at the federal level, the states would immediately turn around and start cutting things at the state level as well, because things can swing back and forth.
Let me just add two really specific things. Katie gave me time to think, which is always dangerous. But two specific things in healthcare where I think you can start to see some signs that just how quickly things are moving. I mean, RFK ran as a pro-choice Democrat, and now he's the Secretary of HHS in a conservative-ish Republican administration. Just today, before I came up, I saw that the ACIP, the ACIP, which makes recommendations, canceled their next meeting. If you haven't seen that, I mean, that's clearly a direct response. I think this just like with DOGE, there was an executive order last week on MAHA, Make America Healthy Again, which came into effect after RFK was confirmed. And I think we'll see, do they fundamentally change the way some of these things are viewed? So you're starting to see that. The addition in terms of just people moving, there's already a Make America Healthy caucus among Senate conservatives. It's not, Democrats and Republicans who want to see food stuff. It's conservative Republicans like Ron Johnson from Wisconsin, who's all of a sudden now on board with the MAHA agenda. And again, is that going to be vaccine skepticism and distrust of our public health officials? Maybe. Is it also going to be promotion of healthier foods and home-delivered meals as part of Medicaid? I don't know. But I think that it's just an example of, I think, to my point about Trump, this is his party, and you can see the influence. And I would bet the over on influence, again, with the restraints of some of these items I talked about earlier, including the courts in the states.
Does anyone over there have a question?
Thank you. I'm really enjoying this conversation too, and perhaps this question, you partially answered it, but I wonder, I'm a general pediatrician as well, and you were talking a little bit about the number of folks that are on Medi-Cal and the percentage of folks that are on Medi-Cal, a third of the state, a half of all the children, and those numbers, I think, within plus or minus, a few percentage points, probably carry out across the entire country. And as it pertains to pediatrics, all of those patients receive their vaccines, their standard childhood vaccines, through the VFC program, Vaccines for Children. And I think we are all alluding to the vaccine skepticism that's coming out of RFK Jr. That we're all aware of. But I wonder if you are tracking on, or if there's a plan around if they come up with some sort of an economic argument for dismantling the Vaccines for Children program, and what will that mean for states? There's going to be big economic impacts just on the healthcare side with regards to preventable conditions. Have either of you heard anything about this, or are states sort of preparing for anything like this coming out of the federal government?
Yeah, I mean, I think really great question. Lots of pediatricians today, so thank you. Yeah, I see a few of you in the audience. I want to put these into two sections. There's the fiscal impact, right? So we stop vaccines for children, and there's a huge fiscal impact. Again, just I would say just add it to our bill. We've got a lot there, right? And not just in California, but of course across the other states. But then there's the what requirements do we have in California, specifically in California state law, and what do other states have in their laws around vaccine mandates for children? And so I think, in California, we have some very strong vaccine mandates for when children go into public schools. There's a huge fight a few years ago around vaccine mandates and exemptions to that. So California, I would say in our California state legislature, people feel very strongly about vaccines. And we've had multiple fights over the last several years around this. And so I actually think in terms of vaccines in California, we're pretty well protected. And we might see, an uptick in, there's the potential certainly for uptick in exemptions for that. But I think the fiscal piece is another one that, again, add it to our bill. It's a lot of money.
In the back. Yeah.
Adding to the Medi-Cal. God bless you, pediatricians, by the way. Thank you. Knowing that half of them are Medi-Cal. I mean, that's a struggle, and thank you. So my daughter's 15 and a half now. We advocated for her as a preemie, and she was in the system, and she became ours when she was 2. And so she's been on my PPO insurance. She still has Medi-Cal coverage, and monthly she gets a check for $1,000 until she's 18. Now, they didn't means check us. We said we don't need this, and they refused to stop it. So my thing in this system, in the numbers, how much of this duplication of, let's just say, kids that are Medi-Cal insured that they don't need it anymore?
Yeah.
So I don't know if you have any comments on it, but I've always been curious about that. It's like, okay, we need to save money.
Yeah.
This is and I don't know how big of a percent it is.
Yeah, no, thank you for sharing. Thank you for sharing this story. I actually go back a little bit to what Sherry said earlier when, we have instances like this, and it sounds like we might need some kind of voluntary program at the state, and there are folks we can talk to about that. But, how often does this happen? I don't know the number of foster youth in California, but I think it's somewhere around 60,000. So when you think about 5 million children who are covered by Medi-Cal and twice that in the state, it's a pretty small percentage. And I totally agree with you. At this point, when we're talking about vaccine for children and all of these little tiny programs, every dollar matters. We don't have a way to do that. And I think in a state as large as California, I think of Sherry's comment about how much time do we want to spend on recouping, that very generously, folks sending in a piece of paper to say, hey, thank you so much, and we also don't need that. We'd have to go into eligibility systems and make a change, right? Put in a change order in an eligibility system to turn that off. I'm not sure what that would look like, but I appreciated Sherry's comment when I think about that. And I also appreciate your thinking, is there an opportunity to go to the State Department of Social Services and say, you know what, we're good. Here you go. I honestly don't know, it's a big state bureaucracy. How do you process those types of payments? And it takes time and effort on the state's part to do that as well.
Well, I'm going to ask one final question before we end this panel. And I'll ask you for a rapid fire answer. Are there bipartisan issues in healthcare that you think Congress can make progress on, or that, a Democratic governor like Newsom could get behind?
Goodness. I do, and I think some of this stems from Dean's comments earlier, when we talk about what really could happen, I do think fundamentally many members of both parties think that Medicaid is important, that we do care about the most vulnerable among us. And so I do think that there is that we can come to some consensus, right? It might be work requirements. And we would all still agree that keeping the Medicaid program mostly intact is important. And then I also appreciate some of the comments, when we look at the MAHA agenda, medically tailored meals. That's part of California's Medi-Cal transformation waiver. We have medically tailored meals where we're delivering meals at home. So I do think there are a few things here and there that we could, from really big, we're not going to completely do away with the Medicaid program, all the way down to some of these smaller, more upstream preventative pieces. And I think, Dean mentioned earlier, they want to save money. And so there are options, and they are probably weighing, difficult questions where, maybe negotiating for pharmaceuticals could be back on the table, but just in a different way than the Biden administration did it.
Well, I think one of the slides I kind of flew past, and you can see it actually has about a dozen issues that Congress grappled with last Congress in a bipartisan way, and I think it's an open question as to whether they make progress on it this year. But there are things where you saw a group of Republicans and Democrats come together, and I thought it was a really healthy process where they put out a bipartisan request for information, stakeholders from states to pediatricians to pharmaceuticals, to everyone would weigh in, and then they'd come up with a white paper and then a bill, and there was a lot of input. And I thought it was a pretty healthy process on things like improving care for dual eligibles, physician pay, AI regulation, supply chain, and other things. And I think, that doesn't get covered a lot. On the other hand, I think one of the reasons we're having these really healthy debates about some of these other things is that, like a lot of other issues, healthcare has kind of been weaponized a little bit in this red and blue shirts and skins, atmosphere that we're in, maybe more in Washington again, because, we are in an era of change elections every 2 years and very, very tight margins. And what's happened is a lot of these tough issues where, and I give both Ovik and Sherry a lot of credit. I mean, there are folks who are trying to figure out, is there a way to sort of come together around helping people with a little bit of a different philosophy, but we haven't done the hard work on, look, Medicaid, Sherry, Medicaid's not a perfect program. I don't think anyone here thinks that Medicaid is super perfect and super efficient, nor is Medicare, nor is the private market with ESIs and other things. You've got really precious few folks, either because of the dollars or the political risk, who are willing to come together and really roll up their sleeves and do that. And I think if you take an issue, last comment, on things like these enhanced tax credits or Medicaid reform, I think if you would have had a center-out group that was working in the same way on these issues as some of the other things I mentioned for a couple of years, and there was a solution that said, you know what, maybe we don't have to have zero premium plans for everyone, or maybe everyone above 400% of poverty shouldn't have this level of subsidy or whatever, you might have a consensus that you could turn to instead of just going back and forth where one party does what they want to do when they get in charge for 2 years, and then the other party tries to undo it. So I have a lot of hope, and I have some optimism, and I think that there's a lot of things that are good ideas where folks could come together, and I hope we get back to that environment.
Thank you so much.